I'm going to hand over to our chair of our next session, Michael Bell, who's the part of the South East ICS and stuff. So they're going to talk a little about he'll introduce the panel. And please do feel free to ask questions at the end. There'll be hopefully microphones available. But I'm going to hand over to Michael for the next 45 minutes. Thank you, Michael.
Shafi, thank you very, very much for that. I'm going to ask the panel to come up and take their seats. So this part of the Giant Health event is focused upon the future hospital. We can't conceive of a future hospital unless we get primary care right. And today's session will be looking at a really amazing piece of work that we've done across London, and we think it gives a really good example of how we can transform primary care as we move into the future. Before we start that, I'm going to ask the panel to introduce themselves. So, as Shafi said right at the beginning, I'm Mike Bell. I'm the chair of South West London Integrated Care Board. I'm also the chair of Lewisham and Greenwich Trust, which is in South East London. And I've So I'm going to go right across to my extreme right, which is not a political statement. Andrew.
I'm relieved to hear it. So Andrew Bland, I'm the Chief Executive of NHS South East London ICB, so we cover the 6 boroughs of South East London. I think I'm here for that reason, but also I'm the co-chair of the London Primary Care Board.
Hi, nice to be here. I'm Michelle Mackey. I'm a director at Ipsos, so I don't work in the NHS, but I support the NHS to engage patients, public and the workforce in transformation, which we're here to talk about today.
Good morning, everybody. I'm Amy Darlington. I'm an Executive Director at Imperial College Health Partners. We're one of the 15 health innovation networks, formerly known as Academic Health Science Networks. And we've partnered with Ipsos to design and deliver the engagement work that we'll talk to you about today.
Good morning, everyone. I'm Nav Chana. I'm a GP partner in a practice in southwest London in Mitcham, where I've just completed my 34th year as a partner in the same practice. I'm also a non-executive director at Lewisham and Greenwich NHS Trust. I'm no longer the chair of the National Association of Primary Care, so I just wanted to make that clear to everybody.
Thank you. So today what we're going to do is we're going to hear a little bit about the piece of work, and I'm going to ask the tech people if they could put back up the screen with a screenshot of the report, and because that gives you the QR code that you can download the report. But we're going to have a presentation from Michelle and Amy about the way in which we approach the report, key findings, and then we'll have the rest of the panel contributing a range of questions. Happy to take any questions from the audience after we've heard from Michelle and Amy. So if I could pass straight across to Michelle, first of all.
Thank you, Mike. So as Mike said, we can't tackle hospitals and keeping people out of hospitals who don't need to be in hospital unless we address what's going on in primary care. And actually in London, there was a big programme of engagement around urgent and emergency care that came to that conclusion. So following that work, London decided to embark on a large and ambitious programme of patient, staff and public engagement to inform the future of primary care with regards to transformation. So we started by talking to regional and national leaders and system stakeholders about their ambition, really asking those big questions. What do you want primary care to look like in the future? Don't think about now, think about the future. And this phase was really important for clarity, but also to get sort of buy-in to that shared vision, to not leave anyone behind and make sure that everybody was kind of on the same page going forward. We next moved on to designing the engagement, and we used a progressive form of public engagement called deliberation, which we borrow from other sectors like climate change and abortion in Ireland. The method is characterised by 3 distinct phases. First off, those involved learn about the issue. Second, they deliberate about the issue. And finally, they come to conclusions and recommendations about their sort of views on the issue. It tends to be used where there are dilemmas, tensions and trade-offs, wicked problems, and invites those involved to grapple with these, finding areas of consensus and ways forward that we can all live with. The questions are not what should we do, and in this case these were new models of primary care, but how should we deliver these? And so at the beginning of the year we started with 40 staff from across London who came together to think about the questions further that were set out by the first stage, and really to discuss these and hone the topics for the public deliberation. In the spring, we moved on to planning the public deliberation. We brought together over 100 members of the public from across all London, a concept of a mini public, which is selected to reflect London's population with regards to demographics and health service use. They participated in an in-depth engagement over 3 days of in-person workshops. They heard the case for change, why we need to do things differently, the draft proposals from experts who presented the benefits, the risks and the trade-offs, and they discussed these at length in facilitated discussions. And finally, on the final day, we supported these 100 people to co-design their recommendations back to London. And in parallel, we engaged individuals and advocates of marginalised groups and patients who might be disproportionately affected by these proposals. And their views sit alongside the public's views in the report that we're going to present. So just before I hand over to Amy, we designed the process across the patient pathway in primary care, thinking about initial access, the concept of a digital front door into primary care, moving on to triage and prioritisation, how we decide where patients go, and then to streaming and onward care. Finally, we discussed integrated neighbourhood teams, which is a concept I'm sure you're all familiar with. So I'll hand over to Amy to talk us through the results.
Thanks, Michelle. So, as Michelle said, we looked at 4 areas. I'm going to talk to you about some of the high-level findings that our 100 participants co-created together. But as Mike said, there's a QR code on the screen there where you can download the full report. There's a lot of detail that sits behind what I'll share with you today. So do download the report and have a look. So the four areas, whilst we discussed certain elements within each of those 4 areas, which I'll talk about, there were 4, we called them 4 C's, that we looked at across all of that pathway. So consistency of care, choice, and how patients should and want to advocate and use that choice, continuity of care, and convenience. So you'll hear me refer back to those 4 C's as I kind of talk through some of the high-level findings. So firstly, access. We looked at acceptability and what patients expect with increasing digital routes and digital front door, as Michelle said. Wide support and broadly a lot of appetite for increased digital access routes within the NHS and within primary care. People felt that this was really important to increase and enable convenience of care and to actually alleviate some of the pressure that we're all very familiar with in this room and patients are experiencing as well. But importantly, making sure that there are alternative options for those who are unable to access via digital routes. And that should always be in place, but a recognition that that's for the minority rather than the majority. And actually we need to speed up digital routes for the majority of patients as well. Importantly, though, that this isn't just about increasing digital access. It's important that those digital access routes are connected to services where there is capacity and they can actually see patients in a timely way. And that was some of the frustration that we were hearing in the rooms over those 3 days, is that currently isn't the case. So great that I've got an NHS app, but not great if it doesn't connect me to a service that can meet my needs. So that connectedness of service was really important. And finally, in access, a key finding was around consistency. So we heard a lot about proliferation of apps. I have an app for my diabetes, I have NHS apps, I have all of these different websites, a website for my GP provider, a website for my hospital trust. And actually that's really frustrating for patients. They want consistency across applications, consistency across online platforms. And that doesn't negate the ability to create for an example, a local services area or a local services button or tab on an application. But actually, we should be looking for the majority of these applications to be consistent, and that was seen to be something important around fairness and equality. So on to triage. So people have gone through their digital front door, and we discussed, well, what happens then and what's your expectations about triaging? We heard a lot around inconsistency of triage in primary care and actually the frustrations that led to. So an expectation that the protocols and indeed the questions that are used to support triage processes should be consistent across digital as well as in-person triage processes. And importantly for patients, that they should be considering social factors as well as clinical factors. So we heard a lot about it's important to take into account access barriers, vulnerabilities, actually other challenges that patients might be dealing with that are important to take into account when we're considering not only where these patients should be going and who they should be seen by, but how quickly that should happen as well. We explored a little bit the role of AI and automation in triage. There was support as well as some nervousness, which won't surprise any of you in the room. But people saw actually the benefits that this could bring, particularly in spotting trends and patterns which actually might not be picked up by humans. But actually, because of that nervousness and concern, a real expectation that these things need to be tested and rolled out with clinician support and clinicians at the heart of designing those processes. So after triage, onward care, there was an absolute understanding that it's not sensible that a GP sees every patient for every need. And I think everybody in the room, all 100 Londoners, understood that. And actually, when we talked about the other roles that are there in primary care, there was a real acceptance and actually appetite to be using those roles more. However, there was a real lack of understanding about what a lot of these roles do. So we talked about examples for, like, physician associates. And I would say probably over half the room hadn't even heard of what a physician associate is, and so felt some trepidation around maybe being directed to one of those roles. So there's a real thinking for us to do as a service around how we educate and communicate about these roles to drive acceptability, because patients are up for seeing other people, but only if they understand what those people do and the skills that they hold. Something around continuity as well, which was important here. So we talked a lot, and actually through the system engagement that Michelle referred to, we hear a lot about this ongoing trade-off between how as a service we provide continuity of care for people who need it, as well as convenience of care for people who want it. And actually the public participants, our 100 Londoners, were saying, give us that choice. If you put the choice in our hands, we can decide whether continuity of care is more important, and that might mean waiting a few days longer, or whether convenience is important, and actually I'll see someone that I don't know, but I'm going to get to see them quickly. Let me as a patient make that decision. And actually there's a really important factor, I think, for us to consider there about the role of patient choice in tackling some of the dilemmas that we face as a service. And finally, integrated neighbourhood teams. So again, support for this as a model of working, especially for those patients that have more complex needs. Although some nervousness, particularly amongst more vulnerable groups, and we did a whole load of parallel engagement with seldom heard and marginalised communities to understand their voices within this. Some nervousness around what that might mean for them, particularly those who don't trust some of the organisations that might be involved in the provision of those integrated neighbourhood teams. And actually some scepticism about the ability of the NHS to move to this way of working, bringing different organisations together. Patients recognise that currently the provision of care feels and is very siloed. So support for, but lots of questions about the how. There was a recognition that they need to be digitally and data enabled, and that actually if you're bringing data together, then we don't need to always bring the patients and the staff together in the same place, and that should be the future. Although that needs to be done safely and securely, there are some conditions to how people's data are being or expected to be shared. And lastly, a discussion around proactive care. And people felt that actually there was a real role for integrated neighbourhood teams in providing more proactive care, particularly in the prevention space. And actually a greater role for patients and the accountability that they should and do feel around living well and reducing the burden from the NHS. So I'll pause there, Mike, hopefully helpful.
Fantastic. Thank you very, very much. It is a really, really important report, really well written, great to read. I think what you captured as well, Michelle, was some of the energy in the room during those sessions. Both Andrew and I attended those, a couple of those sessions, and it was amazing the way in which our population in London was grappling with some really complex issues and working through the things that they were prepared to accept and the consequences of those and the various trade-offs. It is a fairly unique piece of work in the sense of NHS England's London region and the 5 ICBs coming together, producing this, publishing it just after we've had our Adazi's report, which talks about the 3 shifts, including critically a significant shift into primary and community care. So this is a bit of a roadmap towards that. But I'm going to go to Andrew, because I'm really keen to get a sense of what might be the barriers and obstacles to implementing this, and the things that might mean that we could land it quicker.
Thanks, Mike. So, look, few things for me, and I promise I'll get to those points as well. I've no shares in Ipsos or Imperial Health Partners, but the process is worth investing in for one reason, perhaps 2 actually. So engaging the same set of people over a period of time and investing in learning about what you're asking them to do, it seems to be a bit of a game changer for me. So it's no surprise to me that the report is incredibly useful. Do have a read through. So the first thing to say, timing is everything. So I think on the positive, new government, a mandate, this has come out when we're seeking to create and understand what a neighbourhood NHS would be, and at the heart of that, integrated neighbourhood teams. And as far as I'm concerned, integrated neighbourhood teams need vibrant general practice. General practice, to be vibrant, needs an integrated neighbourhood team. So we're on the same page here. In the negative, though, and Mike and I reflected on this twice, maybe 3 times this month, I think the average investment in general practice at the moment is around about 10 or 11% of an ICB, so an organisation that I run's total budget. We're reflecting in South London, be it South East or South West, it's south of that at the moment. So for South East London, it's about 7%. So we are talking about a challenged environment and perhaps an underinvested start point. So important there. Secondly, we will have to do things differently for no other reason than they're happening anyway. So in 2014 through to today, there's 20% less general practices than there were in the capital over that 10 years. Claire Fuller in her report estimated we can expect that to happen again over the next 10 years. So the idea that the same model will perpetuate with that reduction in the units. And by the way, the reduction is for 2 reasons. On the one hand, proactive decisions to scale up, and we'll come on to consistency, I'm sure, or sadly, decisions to close the business because it's not viable anymore. So we've got those 2 reasons for the change. I guess from my point of view, I'll come on to inhibitors, but the report has the 4 Cs. I won't repeat them, but the new one, the one I would encourage you to focus on most is the consistency point. Consistency in itself, I think, makes absolute sense, but equally it's sort of countercultural in the conversations I've been having about general practice, which is very local. And I defend that absolutely, but it's quite clear there is a need for core offers that then have local adjustment for the populations that we're seeking to serve, but we overlook that core, and in this financial environment, that just can't ride any further. I think I would also just endorse absolutely this sort of dual thing with scale. So it's heartening that I think it's sort of pretty much the first statement of the report talks about not just our commitment, but Londoners' commitment to not seeing inequalities grow because of what we're doing in a digital space with some of these shifts. So heartening that people are keeping an eye on that. But then also actually poses as a challenge to say, well, how will we use the NHS app or some of these digital solutions without increasing a sort of an exclusion of sort of really vulnerable members of our community? To the question, and I will stop, Mike, I promise. This is great work. It's coming at the right time, as I've said. But it also needs a couple of sort of hard discussions, I think, and I don't proclaim to have the right answers, but I definitely think I know what the questions are. So at the moment, if we're to focus on populations, I would fully endorse the report's view and Londoners' view that boroughs or populations of 300,000 to 400,000 people seems like the sort of Goldilocks answer. It's not too big, whereby it's generic. It's not too small, by where we can't afford it. At that level, the sweet spot with local government and all the things that local government bring around social care, housing, leisure, tackling crime, that feels to be a sweet spot for this discussion. So that population, really important, particularly given this is a London report in London. Brings together partners at the right scale. They can then help organise integrated neighbourhood teams that respect that local general practice provision. So absolutely clear on that. We don't start in that place. Primary care networks are excellent ways of collaboration between general practices, but they are collaborations of people who are perhaps like-minded or are used to working together, or perhaps might be in different places in London or in boroughs. That doesn't provide the geographical cohesion. So point number one is, if we're to have really vibrant integrated neighbourhood teams in response to this report, we must also work out how can we have collaboration of general practice around populations and not around friendship groups. I'm stealing from an earlier conversation I had today. So first point. Secondly, we then perpetuate that by incentivising general practice to work with general practice. So the primary care contracts, general practice contract nationally, is by definition not local. So first of all, local variation really important. How can we engender that if we're advising a new government with a fresh look at contracts? And secondly, how can we have a contract that says, yes, please do look to your neighbours, but also look to the other parts of the health system which you're trying to interact with. I'll leave you just with one point. So, guys and St Thomas, I've seen some colleagues here, obviously a central London, huge hospital. At any point in time, they are organising discharge on a substantive basis with 14 different boroughs. That means by definition they're probably working with about 45 different primary care networks. If everybody is doing something slightly different without really good reason, we should not be surprised if we've got an inefficient hospital discharge system, which then sucks the money away from the primary care we're seeking to invest in.
Fantastic. Thank you for that, Andrew. I'm going to go to Nav next, but I'm going to go to you for questions in a moment. But I'm going to ask one of Nav, because I've known Nav for a very long time. He mentioned 34 years as a practice partner. During that time, I think it's probably 14 different attempts at reinventing, reorganising primary care. So I'm going to ask Nav what we can learn from those in order that we can actually move forward positively and progressively this time.
Thank you, Mike. And I know the colleagues, Saqib, for example, in the audience will have experienced some of those primary care reforms. So yes, 14 reforms in 34 years. So that works out just under one reform every 3 years. So just to kind of, put that in perspective. And we are currently in the reform phase of the Fuller report and integrated neighbourhood teams, and maybe a new reform to come in the next year or two. So what's the learning, Mike? Thank you. And not taking anything away from the report that you've set out, which is has got some really coherent messages in there. The first thing is the sort of size thing, because general practice and particularly primary care delivery through general practice has always been a size issue. The challenge between small, i.e. focused on defined populations in a very small space, like 500 people with particular needs around one particular area of a street or a block of flats, versus what often commissioners want is scale delivery across larger populations, as Andrew said, covering several 100,000 perhaps, potentially. And of course that's an attractive proposition to commissioners because you're only dealing with one issue at one time, whereas actually, in my experience across 34 years, people want very focused, tailored, very specific, very local kind of responses to their challenges. And as we know, you can walk from one part of London to another part of London, 400 yards apart, and you've got a completely different demographic, completely different set of requirements. So we've got to kind of figure that one out. So the first thing, Mike, was size. Small versus big, that continuous debate about how that works. The other thing that I think I've noticed over 34 years is when primary care, general practice-led primary care worked really well, we had really excellent clinical integration. So when I started as a GP, I kind of knew 50 or 60 secondary care consultants with whom I would interact on a regular basis around a variety of clinical presentations. And through relational care, we were able to sort out quite a few things which nowadays end up in a hospital because no one quite knows how to access the right advice, support that you need when you're handling people with high complexity and so on and so forth. So I think that clinical integration piece, particularly between colleagues who work for who are taking responsibility for the same population, that needs to kind of really be worked out in a way that's supportive of both professionals and people in our citizens particularly. The third thing I think, and Andrew alluded to this, is in my view, too much of primary care reform has been focused on micro management and micro incentives, small little tiny projects which take forever to come to any conclusion and often are abandoned before they start to show any results. And I think the thing that's really made a difference in primary care transformation is taking a population health responsibility. I think we've all agreed with that. But also then collating the resources that you need to support a population through its health improvement journey, and taking a step back and letting that happen, and let people and clinicians and the variety of people we have in our workforce take responsibility for the decisions that are made on behalf of that population, and not interfere or micromanage too much to kind of stop things happening before they show benefit.
It's really helpful. So I did say I'd come for any questions from yourselves in the audience, having hogged the floor with my 2 questions so far. Can I see some hands? Thank you.
Hi, thank you, Chair and panel. I'm a grassroots GP in South London. I've known NAV for very many years. The thing that we have a lack of is data on populations at a practice level. It's a bit like the asteroid. You see it coming, but you need to actually do something about it. And if we're going to talk about what Shafi alluded to earlier, is doing more with what we have and more efficiently, we need that population data. And I'm really interested in finding out whether AI can help to integrate the masses of data that we have in our primary care systems to look at our populations and decide actually which of these asteroids are coming our way and what can we do about it. And there's a dearth of population platforms that we don't have access to. So we would like to see more of that. And I'm interested to find out maybe from this event whether there is such a platform in development, and if not, I'd like to develop one. Thank you.
Really excellent question. I'm going to ask Andrew on that, to come back on that, but I'm also going to ask Amy to say something about the sharing of data piece. But before that, I'll take one more question. Thank you.
Hi, thank you. Thanks very much for the intro. So I'm Sebastian Alexander. I'm a GP in Cambridge. But I just wanted to ask you quickly about obviously workforce is a big problem across the country of GPs, and wonder whether you came to any conclusions around partnership or salaried doctor models and that sort of thing, and whether you had any. That was the first thing. And then a quick one about other workers in the practice. You mentioned PAs very briefly, but also use of paramedics and other people within the practice. We've since folded our out-of-hours service, which is a doctors' cooperative in Cambridge, and that seems to be a big backward step, really. So out-of-hours is a big issue for us as well.
Thank you. So I will go to Nav after we've heard from Andrew and Amy, to actually talk about some of the business model ideas, but also some of the workforce opportunities and challenges that exist. And it might be useful if you maybe reflect upon some of the models like Leeds, where where the community trust, has a key role in supporting primary care networks. But if I could go to Andrew first of all.
Okay, thanks. Both great questions, but Mike, you've asked me to sort of focus on the first one. So, the first thing to say is it's a no-brainer as far as I can see. I don't want to get into the habit of answering questions by asking one, and we can discuss afterwards. But just imagine we did have the data flow coming through. I'm concerned that we don't have the people to turn that data into information in teams that can then best respond to it. So, as well as the data challenge, I'm not avoiding the question too much, but as well as the data challenge, I'm interested in who's coming together to look at that data at any time and then say this is the multidisciplinary, multi-agency way of looking at it. The reason I say that is that we have got some good examples. Actually, Mike chairs a trust that is really good, pioneering, I would say, in bringing together local government social care data with acute and primary care in their electronic care record, and it's unique in the sense that that last bit around social care and otherwise isn't there. So I'm interested in how you bring that together. The inhibitor, as far as I can see, part of interoperability is, are we able to get those people together virtually to do that? In South East London, we've adopted a couple of techniques to bring people together easily for those discussions around data. But one thing I would say is a game changer from my perspective is the London Care Records use in South East London is 650,000 sort of hits per month. That means we have got a huge uplift in the number of people contributing to the same records, or a universal care record increasingly, to then treat their patients. But I don't have the answer to at the moment in terms of inhibitors. However, you may have followed it in the journal this week, we're very interested in planned investment in this. So at the moment, we've got Epic across 2 of our largest trusts in South East London, responding to 4 of our 6 boroughs, but no real way to take full advantage of that with integration with data. So apologies for not having the solution this morning, but I can only endorse the challenge.
So I guess from a public trust perspective, which I know is rightly so a big concern, particularly of data controllers like GPs, in terms of bringing data together and linking that with other data for both direct care purposes, but often secondary purposes as well, like research, planning, and population health management, which I think is what you were referring to there. There's huge opportunity in how we use data to foresee and mitigate against some of the future challenges. So Michelle and I have done a lot of work on engaging the public through deliberative techniques around the uses of health and care data. Spent about 5-6 years doing that together. And I think there are some kind of key points. Firstly, the public expect this to be happening. They want their data to be joined up and to be used for direct care purposes, but also secondary purposes. But that is conditional. So there are things that need to be in place for patients and the public to accept and to trust that their data is being used in an acceptable way. So they don't want to repeat their story. But in the secondary uses perspective of how we might use data for population health management or research, for example, keeping that data in a secure data environment. There are 11, well 12 if you include the national one, across the country, and London has one of those, is really important. So the data stays in a secure environment, isn't coming out of it. There are rules and regulations around how that data is accessed. There is a group, often with lay members sat on it, as well as experts, about making decisions about who's accessing that data and for what purpose. The purpose needs to be for public good. So there are a whole load of conditions and we can share, but the general consensus from the engagement that we do is people are very accepting and want this to be happening because they see the huge benefits that data can yield, but that needs to be done with conditions that meet acceptability to maintain and maintain confidence and public trust.
Thanks, Mike. I'm going to just pick up the population data point. I think that's a point well made, Saqib. I think that the challenge for me, though, is how much data do colleagues need in order to enact a change in the way they deliver care or improve the way they deliver care for those populations that need a different model of care delivery. And I sometimes worry that the language of population health management falls into what I would call admiring the problem. So more and more data which continues to kind of give the same answer without actually moving people into actually doing something differently with the resources that they have. So I guess the question is, what is just enough data to enact the management phase of population health management rather than the admiring the problem phase of it? And then the second bit about population health data is that too much of it's focused on the here and now and not enough about what's the modelling going to look like in 1 year, 2 year and 5 years time, because surely that's the trajectory we need in order to kind of have a sustainable view of where our challenges are going to lie because of all the things that we know, particularly in London. So that's just my view on the data point. Colleague over there asked 2 questions. One was something around the partnership model, was that right? And what the other was a salaried service model. And look, this is a debate that's gone on for all of my 34 years. And I think it's impossible to answer that question without recognising the values of the different models of primary care delivery. What I would say about the partnership model is that there was a review published 4 or 5 years ago led by Nigel Watson, which kind of had a really good look at partnership model and actually came out in favour of the potential benefits of a partnership model. But notwithstanding the challenges around recruitment, resources, workforce that Andrew's picked up, you know, the gradual decline in the proportion of funding that goes into general practice-led primary care. And if we can't correct that, then of course our current and future workforce are going to think differently about where they want to work and how they want to work. And we need to recognise that people want to work in a slightly different way, maybe more flexibly. Issues around childcare, how they want to get a better work-life balance. Whereas the old partnership model was very much nose to the ground, 5 days a week or 7 days a week, right from morning from dusk to dawn. So we have to kind of think about the evolution on that. The skill mix thing, good primary care is a team-based approach. You can't run a primary care provider system without having people who have different skills and attributes. Even amongst the medical side of that, people have different skills and attributes, and we need to leverage that rather than avoid it, in my view. The challenge falls on supervision, training, and development, because often what happens is we end up substituting GPs for people who arguably may not have the same degrees and length of training, but then we arguably don't provide enough supervision support for them when they're handling difficult situations. So skill mix is fine as long as training, education, supervision follow through on that. Otherwise, we end up with a very different and fragmented system. I think is the point you were trying to make.
Great, thank you for that. We're coming sort of towards the end of the session, so I'm going to ask a couple of different questions from our panel. So in terms of Michelle and Amy, we've just embarked upon the consultation for the 10-year plan. So I wanted to get a bit of a sense from them about what they hope the way in which that is approached, so the methodology, the process part will look like. And then I'd like Andrew and Nav to reflect upon where they see primary care in 5 years' time, and linking that back to the theme of this part of the conference, the consequences of that vision of primary care on our hospital sector. A bit of visioning for the 10-year plan, the midpoint, 2029, what have we put in place? But first of all, to you, Michelle.
Of course. So the work in London came at a very kind of helpful point, I guess, because the leaders within the system in London were already thinking about those 3 shifts and engaging the public and, importantly, the workforce on how we deliver that. Not whether, but how. So this has to happen. We need to do things differently. And as we talked about, the public very much accepted that in the work. The staff did too. They've actually found things more difficult in parts to accept than the public, which was a surprise to us, I think. But I think what I'd say about the work nationally is that they are intending, as we understand, to use similar methodologies. But they've obviously got a huge challenge there in that how do they bring, all of that kind of insight together when they've got very kind of different systems and different delivery mechanisms. And actually, the public is a difficult kind of group to grasp if you're looking at a national kind of delivery. So I guess the kind of questions are going to be at a different sort of scale. But what my hope is that they use the opportunity to get into those kind of knotty and difficult issues rather than just hearing what people want and hearing a wish list. Because what we did is we avoided the wish list and we wanted to say, look, these things are not straightforward. We want you to help us design something that we can all live with, which will recognise compromise and trade-offs. And so I suppose my ambition would be that the national work sort of gets into that space. Otherwise, I think we're just going to have a huge wish list from the public that says, we just want more GP appointments, and that's not necessarily going to be deliverable.
So completely agree, and I guess I'd add, look, it's fantastic that we are in the middle of the largest ever conversation about the NHS, and what a brilliant opportunity for people to feed in. but a risk with that we end up with a lot of wish lists. So I think the other thing that I would say, as well as of encouraging those difficult conversations, because inevitably there will be difficult choices, I think the other piece is that this isn't a one-off exercise. This needs to be an ongoing conversation with the public and indeed the workforce about those difficult choices. And I think the work that in particularly has happened in London over the last 5-6 years, this being the latest deliberative exercise, but it's certainly not the first, and I don't think will be the last, actually is setting a different example for how public bodies, in this case the NHS, want to work in partnership with their populations to tackle the challenge and share the difficulties and the tough choices that lie ahead. And actually that has been extremely fruitful for decision makers and leaders in London, but actually really amazing opportunity for populations as well, who feel very empowered and feel a sense of responsibility in helping their NHS too. So I think this is a real opportunity. I hope it's an ongoing conversation rather than a one-off.
So I'll go to Nav for a quick vision of GPs in 2029, and then to Andrew as we come close to winding up.
Okay, just very briefly then, two things I would suggest. One is that we are obviously in the era of technology, and you're at a conference where there's going to be a lot of conversations around that. So how do we harness all of those technological opportunities to create digital healthcare ecosystems which talk to population health prevention, access, analytics, coordination of care, integration of care, primary care, secondary care integration, all of those things which actually work with very little in the way of some of the sort of infrastructure we have at the moment, which is creaky, maybe not always responsive to the needs of the workforce and our patients. The second thing I would think as visioning forward is actually bringing together all the elements of care around defined populations. So whether that's an estate strategy which creates better opportunities to co-locate with clinicians and diagnostics and all the other kind of opportunities that we have, or whether it's a workforce change so that we have the workforce designed around the needs of a population, as opposed to currently a workforce which is just a sort of pull on a lever, and in 5 or 6 years' time we might have the right people, arguably.
I was hoping Nav would go after me, just so it don't end on a low point. In 2029, I want the best features of general practice to still exist for our communities, and I think that's a prize that's well worth fighting for, but something that's at risk at the moment. So, for 2029, I would very much like to see, if I think about South East London, we think we've got 28 natural communities that our population relate to. I'd like to see general practice, the best features of it, the front door, the community aspect, the holistic care provided to those communities as part of a wider integrated neighbourhood team that would involve secondary care, organised on the same basis, social care, voluntary community sector, and engage on an asset basis people who live in that area to say, yeah, this is how I can contribute to my health and well-being. So I guess that's point number one. Secondly, and I didn't want to end on this particularly, I think there needs to be a recognition that the agility and ingenuity of general practice is based on its business basis. These are businesses with business decisions. So I want the business case to be available, that it would be a no-brainer for general practice to organise in that way. So by all means hold contracts, but the business model behind that, I would like a conversation about how does one best collaborate on greater scale. To Nav's point, what's the right size to provide some of those things that make it tick, affordable and vibrant, most importantly.
Thank you to my panel. Shafi, over to you.
Thank you so much. Very kind. A round of applause for our amazing panel. So do we think we've solved the problem of primary care in that 45 minutes? Maybe. 14 reforms over 34 years now. We're saying we have a new report worth having a read. Look, we're going through a lot of change. I think one of the things about where we are is at least we've acknowledged the NHS is broken, it needs fixing, we need to change it around a bit. Tech is coming in, we've got amazing thought leadership, reformation of the NHS as a whole with ICBs. I'm actually, for the first time in 31 years, optimistic that maybe these reforms will lead to lasting change because we've got some solutions out there. So thank you so much for sharing your thoughts with us. Thank you so much.